Yeah, you can go
Okay.
ahead.
All right. Thank you. So I'm Dr. Fatima, and I'll be taking the practice question 9. So the question goes, a 48-year-old laboratory scientist with significant alcohol intake, um, multiple sexual partners, weight loss, and 2-week history of jaundice. So the questions are, what other history would you take? What other examination findings would help you arrive in your diagnosis? List 5 differential diagnoses and interpretation of the results there. And what is the diagnosis? What other investigations would you do? How would you treat? And what is the prognostic score called? And what are the parameters? So the other history that I would like to take include the history of hematemesis, hematochezia, melena, right upper quadrant pain, and abdominal pain. Then early satiety, pruritus, hiccups, vomiting, diarrhea, constipation, history of reversal of sleep pattern, confusion, headaches, loss of consciousness, seizures. And I would also like to take the history of IV drug abuse, whether he has clarification marks done, history of coping, his occupation here, he's a lab scientist, then sharing of sharps, previous history of blood transfusion. Is he aware of his hepatitis status, hepatitis C, hepatitis B, then history of fever. Then what other examination findings would help you in arriving in your diagnosis? So the examination will reveal the peripheral stigmata of chronic liver disease, such as fluffy hair, hair loss, palmar erythema, parotid fullness, hepatomegaly, splenomegaly, and the others. So the 5 differential diagnoses are, it could be a decompensated alcoholic liver disease, chronic liver disease secondary to viral hepatitis, non-alcoholic fatty liver disease, primary liver cell cancer, and drug-induced liver injury. So interpretations of results. So there's a derangement in the AST, ALT functions, values. So the patient has leukocytosis and then macrocytic anemia. So what other investigations would you do? The food block count and film done could show leukocytosis, thrombocytopenia, microcytosis. LFT would show a derangement in liver functions, elevated AST, ALT, albumin less than 3 grams per liter, total bilirubin greater than 3 milligrams per liter, and then GGT more than 100 units per mil. Then the clotting profile, there will be derangement in the prothrombin time, and then INR more than 1.5. Viral serologies include hepatitis B surface antigen, hepatitis C viral antibody, and then anti-hepatitis A immunoglobulins. So EUCR will show us hyponatremia, hypokalemia, hypomagnesemia. Ultrasound scan can be done to look at the liver architecture. Also, transient elastography can be done, and it is going to show us fibrosis, or helps us in detecting fibrosis. So alpha fetoprotein, liver biopsy, then infection screening such as chest X-ray, urine, MCS, blood culture, and then acetic fluid culture as appropriate. So my diagnosis now is an alcoholic hepatitis, which is supported by the history of significant alcohol use in this patient, the jaundice that he has, early jaundice in 2 weeks, then macrocytic anemia, leukocytosis, and increase in the ALT and AST, and is usually less than 400, which is not up to 400 in this patient, and then the AST-ALT ratio that is greater than 2. So how would you treat this patient? Abstinence and nutritional supplementation remain the cornerstone in the management of alcoholic liver disease. So the abstinence encourage patient to stop alcohol um, ingestion completely, and then also involve other team members is a multidisciplinary management involvement of the psychiatric doctors, and then also for the nutrition, you recommend 2,000 kilocalories per day, and also vitamin supplementations like the folic acid and vitamin B. Also, corticosteroids is used for severe acute alcoholic hepatitis in some patients. And also, there is also the use of traditional pharmacologic agents like disulfiram, composite, topiramate, baclofen, but it has not been associated with prolonged abstinence. So it is used in selected patients. So then we treat for all the complications that occur, such as hypoglycemia, ascites, infections, and encephalopathy, and then liver transplant, which is the gold standard treatment if patient meets the criteria. So what is the prognostic score called, and what are the parameters in this score? So we have the Child-Pokot score, which is used to assess the severity of cirrhosis, and it uses the parameters, which are the encephalopathy, the prothrombin time, the ascites, the albumin, and the bilirubin. So the other scoring systems, we have the Madrid's discriminating factor using partial thromboplastin time and total bilirubin. And then when this score is more than 32 is an indication to use steroids. Then we have the Lille model score, which is used to evaluate treatment response of corticosteroids after 7 days. Then we have the MELD score, which assesses mortality and risk in those with portal hypertension. So I'm going to go through alcoholic liver disease, and this is my outline. Chronic and excessive alcohol consumption is a global healthcare problem, which leads to clinical illness and pathological changes causing alcohol-associated liver disease. And this is associated with liver inflammation, injury, or progressive fibrosis, producing three major classes, which are fatty liver, alcoholic hepatitis, and cirrhosis. So for the epidemiology, heavy alcohol consumption is a major cause of morbidity and mortality. And then globally, it has been noted that the alcohol per capita consumption rose from 5.5 liters in 2005 to 6.4 liters in 2016, and is projected to increase further to 7.6 liters in 2030. Currently, Europe has the highest level of alcohol consumption. However, it is projected to be surpassed by other countries in the Western Pacific region by 2030. Alcohol was estimated to be associated with 1/4 of global cirrhosis death and 1/5 of liver cancer in 2019. The risk factors of drinking, as well as the type of alcohol consumed, is a significant risk factor. So the pattern of drinking, including binge drinking, drinking out of meal, is associated with increased alcoholic liver disease. And then the type of alcohol include ingestion of spirits and beer is also associated with that. Then the gender, the female have higher risk to develop alcoholic liver disease, because this is due to the variability of the alcohol dehydrogenase in the females, and also the liver mass, which is more in male. Then viral infections. Studies have shown that those that have co-infection. Hello? Okay, so viral infection studies have shown that those that have hepatitis C co-infection with alcohol misuse have accelerated rate of developing alcoholic liver disease, and then malnutrition is also associated with the development of alcoholic liver disease, and the acceleration because of deficiency of vitamin A and E, and which worsens the liver injury. Also, diet in high unsaturated fats is also associated with worsening or development of the alcoholic liver disease. Obesity, diabetes mellitus, and metabolic syndrome associated with alcohol misuse, or chronic alcoholism is associated with the development of ALD or worsening of the ALD. So for the genetics, we have there's a significant variability that has been noted among patients in regard to the susceptibility of development of this alcoholic liver disease, as well as the severity of symptoms. So some studies have reported the downregulation of the cytochrome P450, and certain genes were also found to be correlated with the severity of the disease, such as the tissue inhibitor of metalloproteinase 1 and growth-related oncogene is associated with all the increased risk of developing alcoholic hepatitis. Also, total patients with a higher total bilirubin with variants of the patatil like 3-phosphate domain containing protein 3 is and the haptoglobins are associated with the development of alcoholic hepatitis. And then seasonality, it has been noted, a study done in the US, that admissions into hospital is more during the summer than the winter months, as it was previously thought to be so. This is just a diagram to show what I have discussed. So for the pathogenesis, alcohol is, if there's a chronic alcohol ingestion, it is in the liver, it is metabolized through three pathways, which is the alcohol dehydrogenase pathway, the catalase pathway, and the cytochrome P450 2E1 pathway. So as it undergoes this oxidative stress in the liver or in the hepatocytes, it leads to a reduced ratio of this NAD to NADH. And this promotes lipogenesis by inhibiting the oxidation of triglycerides and fatty acids. And also another known mechanism is the translocation of endotoxins in the form of lipopolysaccharides and from the intestine into the hepatocytes. This is also worsened by the malnutrition that patients have in the presence of zinc deficiency that the patients have. So in the hepatic Kupffer cells, the lipopolysaccharide binds to the CD14 and toll-like receptor, which leads to a release of reactive oxygen species, and this leads to the release of cytokines such as TNF, interleukin 8, and platelet-derived growth factor. And this leads to the accumulation of neutrophils, macrophages, and systemic clinical features of alcoholic injury. So the clinical features was mentioned earlier: the nausea, vomiting, the right upper quadrant pain, anorexia, fever. Then the examination findings include gynecomastia, parotid hypertrophy, palmar erythema, and the others. So diagnosis is based on good history, and some of these alcoholics, they tend to be reserved with information. So sometimes we have to use their family members to get the history, and also we can use the cage questionnaire that is being used by the psychiatrists in the management of alcoholic use disorder. Then physical examinations, lab findings as mentioned earlier, then the imaging, then biopsy, for which the histology would show a hepatocyte ballooning, neutrophil infiltration, and then Mallory-Denk bodies. So this is just a diagram to show us the different derangement in the lab parameters as we've discussed earlier. So treatment, as we say, abstinence is the most important parameter there. Then the nutritional support. So then these are drugs that are under clinical trials, such as the anakinra, the N-acetylcysteine, granulocyte colony stimulating factor, and then the others. So prognosis: patient with severe alcoholic hepatitis with an MDF score greater than 32 have 30-day mortality of 30 to 50%. Then 40% of the patients with severe alcoholic hepatitis die within 6 months of the onset of the clinical syndrome. Jaundice and hepatic encephalopathy at the time of presentation indicates a poor outcome. Mild alcoholic hepatitis generally runs a benign course and is completely reversible with the complete cessation of alcohol consumption. So complications include variceal bleeding, hepatic encephalopathy, thrombocytopenia, ascites, AKI, iron overload, which they get. Some of these wines and beer that they take are fortified with iron, and that's how they develop the iron overload, and also cirrhosis, PLCC, sorry. So conclusion: alcohol misuse is a leads to alcoholic liver disease, and it has a devastating impact on the individual's health, and it profoundly affects society's health and socioeconomic burden. Abstinence remains critical in maximizing the chance of hepatic recovery, and then corticosteroids continue to play a role in selected populations. Detecting ALD early is crucial, and a multi-holistic approach is needed to reduce the burden. These are my references, and then thank you for your time.
Yeah, thank you, Dr. Fatima, for a wonderful presentation. So it's time for contribution, questions, and comments. You can raise your hand tunically and ask your question. Okay, Dr. Tanimu is saying, I didn't hear you say anything about the unit quantity allowed based on gender per week.
Okay.
Dr. Success says, thanks for, please, apart from hepatic encephalopathy, what other important neurological complications associated with alcoholic use disorder?
Okay, so the neurological complications include the Wernicke's encephalopathy. And for the units, I think is 14 for female per week and 21 for males, if I remember well.
Okay. Okay, usually we prefer using grams per day.
Okay. So
So
okay, I think there's for women who consume more than 40 grams per day, and then for men, those that consume more than 60 grams per day for more than 6 months.
Okay, well, in the context of alcoholic hepatitis, usually within 60 days, people that consume alcohol more than 50 grams per day. So, but for pure alcohol, greater than 40 grams per day is significant for men, and 20 grams per day for women.
Okay. Thank you.
Okay. For stereotherapy, you need discriminant function and Glasgow score. Okay, Dr. Okam is just adding that. Kelly Robert said, thank you so much. Please, can you mention those pathways of alcohol degradation? Momodu Jafar said, is alcoholic liver disease a spectrum to the universal accepted alcoholic unit for both male and female? Okay, we mentioned that. Is there a reason why alcohol toxicity is more in women? What is Mashaba big money syndrome? Okay, is alcohol use disorders. Okay, Dr. Shiki said hematochezia is a lower GI bleeding symptom, except a massive upper GI bleeding. Yes, that's true.
Yes.
How to differentiate the three subtype: fatty liver, hepatitis, and cirrhosis of ADL. Okay, Mosope has answered Dr. Jafar Mankiava. Big means it just affects the corpus callosum, while when it case affect the familiar body.
Okay.
Can RVD be a differential here? And Tanimo said saturated fats more associated with fatty liver, not the unsaturated, as you said. I think those are the comments.
Okay. So for the pathways, we have the alcohol dehydrogenase pathway, which is in the cytosol. Then we have the catalase pathway, which is in the organelles, as the peroxisome, then the cytochrome P452E1 particularly. Then what else? Then I can't remember the other comments.
Okay, most of the other comments have actually been some people. Okay, Dr. Jamila, you want to make a contribution?
Okay. Good morning, our teachers and participants. Thank you very much, Dr. Koleri, for the wonderful and lucid presentation. I just want to make an addition. So for patients who have contraindications or who you may not want to use steroids for, another alternative is pentoxifylline. So I don't think I heard that. Then also in your investigations, another specific test that can be done in alcoholic hepatitis is the carbohydrate deficient transferrin. So that's also a specific marker for alcoholic hepatitis. Then of course the Ritis ratio, which is the ratio of AST to ALT, which is greater than or equal to 2:1. So that's kind of narrows it down to alcoholic hepatitis when you are looking at the enzyme levels to compare or differentiate from non-alcoholic fatty liver disease or viral hepatitis. Thank you.
Thank you very much.
Dr. Lighter.
Yes, sir. Thank you for the presentation. I was just wondering, in the question, we're told that this person is a lab scientist. The issue of occupational exposure and hepatitis B status, vaccination status was not mentioned when I heard about the risk factor that he was talking about. I think we should also take consideration to that. There is a reason why they mentioned the profession. Thank you.
Yeah, Dr. Rahim. Dr. Rahim.
Hello, good morning.
Yeah, good morning.
Yes, thank you. Just a little maybe contribution from the question. I think it was mentioned the index patient has significant alcohol intake. The duration was not mentioned, but for it to be significant, there's a specific definition for significant alcohol. Then it was also mentioned that the patient has a history of multiple sexual partners and also being a lab scientist. The differential diagnosis that the presenter gave, I think, is quite okay. But the final diagnosis, I doubt if it will actually be alcoholic hepatitis, because I see this as actually a chronic thing. And also with the history of just recently, 2 weeks before presentation from the question, the patient now developed jaundice. So I think it's more of a decompensated liver cirrhosis. Also considering the weight loss too mentioned in the question, a decompensated liver cirrhosis, and the etiology now could be the alcohol. We could also query viral hepatitis too as also part of the maybe chronic viral hepatitis as part of the etiology for the decompensated liver cirrhosis. Also in the labs that was mentioned, of course, patient has anemia, 28% of PCV. There's also reversal of the enzymes too. We know that apart from the Retes ratio, in which the AST to ALT will be at least 2 to 1, also in cirrhotic patient too, there's also reversal of the pattern of the enzymes, and AST is usually elevated in cirrhosis more than the ALT, which the patient also has. So I felt the final diagnosis would have actually been a decompensated liver cirrhosis, and the etiology will be the alcohol. Then we have to also query viral hepatitis too. Just as what the previous the person that made comment just said, the occupation of the patient too, we cannot throw it away. Being a lab scientist, also we also told patient also has history of multiple sexual partners. So that was not reflected in the final diagnosis of the presenter, and I think there must be a reason why those points were actually mentioned. So I felt the final diagnosis shouldn't be alcoholic hepatitis, and it should be a compensated liver cirrhosis with those etiology, and maybe we can now manage in that line. Just few contributions. Thank you.
Dr. Fatima, do you have a response to that?
Okay. Why I went for the alcoholic hepatitis is that the significant history of use of alcohol, and then also as mentioned in the pathophysiology, it has been noted that those with alcoholic hepatitis develop the jaundice early because of the infiltration or damage of the hepatocytes by the alcohol. And then also they have leukocytosis, which is also part of it, and then the macrocytic anemia. In fact,
But also
if,
noting that alcoholic hepatitis 2, by its definition, had a specific duration by which they must have been taking the alcohol. It's usually like 3 to 6 months. And this
yeah,
question, we were not told a specific duration. We were just told his age and he has significant alcohol intake.
yes,
And then
and then
together with,
okay,
so I
then
just felt it's actually a chronic thing.
yeah, but looking at the microcytosis is even a useful diagnostic indicator of alcoholism, and also as a part of the investigations mentioned include the liver, the viral serologies. So also I agree. Okay, maybe after the screening, patient is better and is negative, he can go for immunization for the HPV, and then
Okay.
also the
Okay. So
AST-ALT ratio supports alcoholic liver disease. Yes. And
all right. So it can still go for alcoholic hepatitis. The other the other risk factors mentioned. If you recall, so we don't have a full what the question looks like because of course we need durations of alcohol use and that. But from the picture and from the investigations that were listed, it will still sail true for alcoholic hepatitis from the explanation she gave. Well, alcoholics usually they look, you know, like chronic ill-looking patients because, of course, there are other problems with alcohol. We have malnutrition. So they tend to have malnutrition. So when you see this kind of patients, this person is having a chronic illness, and then yes, alcoholic liver disease is a spectrum. So they might come and look like people that have the compensated liver cirrhosis. Alcoholic hepatitis 2 can come, with complications of chronic liver disease. Like, for example, they can come with hepatorenal syndrome also. So that could also look as if, oh, this patient is coming down with. But from the picture painted from the question, I think it will still sail true for alcoholic hepatitis with, background, malnutrition in this patient based on the information we have. Yes, the compensated liver disease, acute hepatitis, either viral hepatitis, hepatitis B or hepatitis, can be a differential for this patient. PLCC can be a differential for this patient. So we are not having a full picture of the question. So that we don't waste too much time. Yes, ma'am.
I think we should round up this session. I appreciate the speaker. I love the way she defended her diagnosis. These were valid points, really. I think, but I will just call our chief Cookie if there's anything she need to fight in. Just to make it clear, I think we should round up this session. So I will move over to the next session. We appreciate everyone, Dr. Yusuf, Dr. Tanimo, all the doctors. I didn't get all the names. Everyone, the gastroenterologists that spoke up. I'm sure Chief Cookie will be very proud of you guys. Thank you so much for making it an active session. Chief Cookie, I don't know if you want to fight in anything.
Yeah, good morning, everyone. Thank you to the presenter. Yeah, so just as they've all said, I don't want to drag it. I think there are one or two things that are missing to really, buttress the points. But if I was in that exam, I would have gone for a decompensated alcoholic liver cirrhosis. So that's what I would have gone for, because I think with the presentation and even the lab investigations, it tells us that this is not just an acute picture, because so many of the changes, you would see them occurring in the chronic setting. And then, of course, with the occupational history and all, of course, the viral hepatitis is close by. And then with the most feared complication of chronic liver disease being primary liver cell carcinoma, it also stands as a differential. And then, of course, the way the Madrid discriminant functions, the Lille score, the Glasgow alcoholic hepatitis score. So there are different scoring systems that we use as to know whether he will benefit from use of steroids in his management or not. And then that is also a contraindication will be if there's background sepsis. We won't want to give the steroids at that time. So I think by and large, every other aspect of the history was in keeping. Thank you very much.
Okay, thank you very much, ma, for the contribution. Okay, can we quickly go to the next? Dr. Prince, are you in the house?
So my name is Prince. Good morning. I'm answering April 2022 recall. The question 5A was a case of a 47-year-old man with typical MI and blood pressure of 80-50 millimeters of mercury for about 2 hours despite inotropes. The serum electrolytes and urea creatinine was normal, and he had a CT coronary angiography done. He subsequently noticed cold extremities, markedly reduced urine output, and some skin rashes. Also noticed to have a low BP and tachycardia.
Sorry, Doc. Can you put it on PowerPoint? Okay.
Oh.
You can use slide share.
Let me see. Is that okay?
Yeah.
Yes, much better now.
Okay. So he noticed he had a CT and coronary angiography done. So subsequently noticed cold extremities, markedly reduced urine output, and some skin rashes. And he also noticed to have a low BP and tachycardia. Then 2 days after the procedure, which is the CT coronary angiography, his serum urea level was 10 millimoles per liter, and the serum creatinine rose to 300 micromoles per liter. Urine microscopy showed granular cast. And there was a note that some candidates had clinical scenarios with rashes, others with skin discolorations, and others with neither skin rashes nor skin discolorations. So the first question was, what was the diagnosis for this particular patient? First of all, we've been told that the patient had an MI, typical MI. We've already been given the diagnosis of the patient premorbid condition before this, but we also see that 2 days after the angiography, the patient had a creatinine of 300 micromoles per liter from the baseline, which was apparently normal. So it appears that putting everything together, judging by the fact that we know the patient's premorbid condition of having typical MI, the patient had developed an acute kidney injury based upon the presentation that we've been given here. And the second question is, what are the causes for this patient's acute kidney injury? What could account for this? And then if you look at the question, then we have a patient who has MI, has a low blood pressure, 80/50, and was not even responding to inotropes, and possibly in cardiogenic shock. And after angiography, also develop worsening creatinine with rash and all that. So if you look at this scenario, it looks as there could be possible causes for the acute kidney injury in this patient. And one of them would be a possible contrast-induced nephropathy, which also typically occurs within a setting of 40 to 72 hours, which is there. And the other thing to look at also is a possible the cardiogenic shock in the context of cardiorenal syndrome, the hypoperfusion, and all that also causing acute kidney injury. The other causes to consider in this patient is cholesterol emboli syndrome or arterioembolic AKI in this particular patient, even though we've not been told the patient whether the patient underwent a catheterization or not. I mean, it could also occur spontaneously. I mean, any risk factor for any arteriosclerotic disease could be a risk factor for cholesterol emboli syndrome. And the other thing to look at is tubulointerstitial nephritis, AIN, and because we are not privy to what medication the patient was given before and all that, but tubulointerstitial nephritis or acute interstitial nephritis, especially the allergic type, could be as a result of almost every other medication or even from contrast through the hypersensitivity reaction. So from the question, these are possibly the 4 major causes of the acute kidney injury. And the subsequent question was like investigations to do in relation to this particular patient. Since it's quite broad and the patient has an acute kidney injury, then again, you can't look at it in isolation with respect to the fact that we've already been given a preamble as to the fact that the patient has an MI. So we will have to look at our basic ECG as well, just to find out if there's any electrolyte abnormality and the fact that the MI, as which part give us an idea about the possibility of the territories involved, whether we are doing something anterior, something inferior, because that will also give us a clue but this is a patient who possibly, we don't know whether the patient underwent PCI. I mean, with the question, it was like we're given scanty information before the 2 days. And also to do an echocardiography to assess the ejection fraction and look at whether there's any regional or motion abnormality and what territories to do. Then one of the newer molecules, the lipoprotein A, and then of course the lipid profile to look at the LDL, and then risk stratification. 47-year-old with MI, you want to be sure the patient is not diabetic, so HbA1c will be key here. Then clearly, since we are thinking about pro-renal component, we might want to do a fractional excretion of sodium. If it's less than 1%, you know that it tends or put the trust more towards pro-renal as opposed to maybe the interest, because of the interplay of multiple etiological pathways in this patient's presentation. It looks more like a multifactorial AKI. And then clearly the creatinine and the renal function as well. Then the urine and microscopy, which are buttressed further in the review, so that at least we know the various conditions or possible differentials and causes and what to expect. Then hepatitis B, C, and retro serologies, just in case the patient may require transplant, the patient may require dialysis and all that. So you need to know all these ones. Then one of the newer molecules that has been investigated is serum cystatin C and the serum NGAL. I will talk about all of them subsequently. So the management of this patient, I mean, we are told the patient developed worsening renal function after 2 days after CT coronary angiogram. The patient has been receiving inotrope for 2 hours and hasn't seen any response in the BP on the background of the typical MI. So in this patient, ideally you will need to monitor the central venous pressure, or if possible, do a pulmonary artery catheterization so that we'll be able to assess the fluid and vasopressor management. Because this is a patient, we don't really know exactly whether the patient is already in pulmonary edema, even though there is evidence of some cardiogenic shock and all that. So it's imperative that you know that. And also in the context of patient with right ventricular infarction or an inferior MI, then the presentation will be that of a pulmonary embolism, where giving fluids will be key in this particular scenario, just to show up the preload and subsequently also increase the afterload in those patients. So you can't do it blindly because this is a critical patient, and then you obviously have to have those monitoring done so that you'll be able to assess very well your pulmonary artery pulsatility index and all that as well. Then one other thing we can do for this considering patient is receiving inotropes, and then we have worsening renal function and all that. And one of the things to consider is intra-aortic balloon pump in this setting, even though the CRIPS trial actually didn't show much evidence in terms of patients receiving intra-aortic balloon pump in the context of absence of no cardiogenic shock. But subsequent shock 2, IABP showed that, it decreases, the tendency to have dialysis and all that, even though overall, in terms of recurrence of the MI and then mortality, there was no benefits. But with respect to the dialysis, the need for dialysis, which in this case, we have worsened renal function, which probably may come to that as well. So it's important that we put this patient, we consider intra-aortic balloon pump and to show up the BP, so as to also improve the renal perfusion and helping also controlling the disease as with the disease and pathophysiologies. And the other thing to also look at is this antiplatelet therapy non-fascinator. This one I left it broadly because the thing is that the question gave us so many things. The thing is, you have a patient who has resting renal function, typical MI. Is that the patient has been on aspirin already? at some point and has like autoimmune interstitial, tubular interstitial nephritis from drugs, or we are not really sure for whether from NSAIDs, because we know one of the things that can do tubular interstitial nephritis is NSAIDs, and whether the person has been on aspirin or not, we are not really sure. So, and this is a patient with worsening renal function, and usually unfractionated heparin in this patient will be the best context, will be best as over low molecular weight heparin like enoxaparin in this particular patient. So, I mean, aside the fact that we are trying as much as possible to show up the BPs to help with the renal perfusion and all that, we also need to have the background of the fact that the patient has a typical MI. We don't know if the patient underwent a PCI, but it's been 2 days. So clearly your antiplatelet therapy and your heparin should be on board. Then clearly, if you are thinking of interstitial nephritis, you want to also subsequently stop the offending agent in this particular context. Exactly, if you've given anything before, or the patient is on anything that is inducing the interstitial nephritis or the tubular interstitial nephritis. Then you may consider hemodialysis to stabilize the patient, especially when you have worsening potassium, and then by conventional therapy, you are not getting on top of it. And then you want to do hemo, or maybe if you have
Dr. Prince.
Yes.
Yeah, the time is fast spent. So can you round up? Can you just summarize so that we can give time for people to contribute?
Okay, all right. So all right, that's fine. So then the last question was, what medication would you give? That question, I think I'll go through the literature quickly. Then we probably answer that. To be honest, I didn't know what he wanted. I didn't know the trust where to put the focus on, because it was like, what medication? Whether it was a reference to the MI or it's reference to the fact that the patient had AKI. So basically, we look at the spectrum of AKI in patients with MI. And by definition, we know that AKI is increasing the serum creatinine of greater than 0.3, which is 26.5 micromoles per liter within 48 hours, or increasing the serum creatinine of greater than or equal to 1.5 times. So basically, if you look at our question, we over-satisfied this criteria for an acute kidney injury, which was normal. So the first one is a contrast-induced nephropathy, which is defined as a 25% increase in serum creatinine from baseline, or when you have a 44 micromole increase in absolute creatinine within 48 hours to 72 hours after IV contrast. And mostly this has to do with iodinated contrast, because of the fact that they are very ionic and the ability to induce a lot of redox reactions, and subsequently generate a lot of reactive oxygen species and all that. That in itself can maybe induce apoptosis of the renal cells through both the direct and the indirect pathway. And usually with CIN, they usually peak between 2 to 5 days and return to baseline in 14 days. So the creatinine usually between 2 to 5 days, you see that the creatinine will peak. And then within 14 days, the prognosis generally is very good. And the pathophysiology that I've already mentioned has to do with the reactive oxygen species, the direct toxicity through both the direct and indirect pathway, inducing apoptosis and release of caspases and all that. Then also, they also disrupt the renal microcirculation. And one of them has been the asymmetrical diameter arginine, which inhibits NO synthetase in all isoforms. So basically, NO is supposed to cause vasodilatation, but this would lead to vasoconstriction and then hypoperfusion, subsequently cell injury as well. And then it also helps, it increases vasoconstrictors like adenosine and then vasopressin, endothelins, and angiotensin too. So all this contributes to the toxicity to the renal cells. Then the osmolar property of the contrast medium also increases the interstitial pressure.
Dr. Chris, we might just have you drop the slides so that we can answer that question,
Okay.
So you drop the slides, and if there are any contribution you want to refer to the slide, you can do so. So let's open the floor for questions, contributions, please. Okay, so I'll read from the chat box. But okay, Dr. Adekola Days, I think this patient has contrast-induced AKI. Dr. Rahim, you say the diagnosis is atherosclerotic renal disease. Dr. Emmanuel is saying the MI looks like a right coronary artery MI that may present like shock. So is it possible prerenal AKI due to hypovolemia in this patient as a differential? Dr. Oladekon is buttressing the fact that AKI is secondary to atherosclerotic renal disease. So did you get?
Yes. Yes, so I think basically we're not to the patient underwent like catheter manipulation above maybe the renal arteries or anything, but he had like a CT coronary angiography. So technically, we are not sure, but as I already said, cholesterol embolized syndrome can occur in the context, can occur spontaneously in any patient with atherosclerotic disease. So clearly, the person has a typical MI, then that's also a differential to consider. But I think there's so many things to consider in this particular context. It's difficult to say that is this. At best, it will be a multifactorial AKI if you want to be safe, in order to because you can't isolate it to say that it's atherosclerotic, because I mean we're not given a lot of other clinical symptoms like the purple toe in cholesterol emboli, and then typically they will do worse than hypertension as opposed to low BP and all that. So if you want to go into it, you realize that maybe you might probably even say that it's not cholesterol emboli syndrome, because typically they will have a show up in the BP, but this is the patient who probably is in cardiogenic shock, because that will also be a bit like contentious. And then basically that's
Dr. Nebo has something to say, the nephrologist.
Okay, yeah, Dr. Chidima, you can go ahead.
Good morning, my teachers and colleagues. Okay, well, in my own opinion, if I had seen this patient in exam and there was the presence of rashes, I'll probably go for the atherosclerotic syndrome, because obviously the rashes might have meant that he has the presence of livedo reticularis, which is found in patients with this syndrome. And the thing is that the patient had had an MI, and what they said was that it was after, well, I don't know, maybe I can't remember the question clearly, but what they said was after he went for the CT angiography, obviously maybe as some form of intervention, that's when this whole thing started, the increase in creatinine and all that. So I'll go for it before thinking of a contrast-induced nephropathy, in my opinion. Then secondly, some other investigations that he can do, at least to make it, to know whether he really has the atherosclerotic syndrome. Increase in the eosinophil level, eosinophilia, if there are low complements, if there's also an increase in lactate hydrogenase and elevated serum amylase, those with leukocytosis, those things are tells signs for the patients who would develop this, who would have this. Then I don't know whether you mentioned something about anticoagulation. I don't know, because in patients that have this kind of thing, in fact, anticoagulation is not, it's kind of prohibited. You shouldn't anticoagulate until maybe when the patient is more stable. You can now start the patient on maybe focus on secondary prevention, such as giving the patient aspirin, statins, and maybe if the patient has any BP, hypertension, you can give the patient good, that's BP control. Then basically for this kind of patients, even in those with contrast nephropathy, well, for this kind of patient, it's just basically supportive. So if the patient needs, like you said, if the patient needs any sort of inotropes or something to get the blood pressure high, to elevate the blood pressure, because before it's like I'll call it a pre-renal stroke, intrarenal acute kidney injury. And for pre-renal, the main thing is to try and target the cause of the kidney disease. So if it's to give inotropes to increase blood pressure in order to increase perfusion to the kidneys, yes, it's fine. Then, of course, you should understand too that in patients like this, because their blood pressure is quite low, if the patient will eventually need hemodialysis, it's not the conventional hemodialysis that should be used in such patients. The patients would benefit more from either SLED, that's slow low efficiency dialysis, or the patients could do a continuous renal replacement therapy where you have with those sort of dialysis, the tendency of the patients becoming having hypotension and all that will be a lot lower, and clearance will be better. Thank you.
Yeah, thank you, Dr. Yes.
Dr. Yes,
Yes,
Dr. Nebo. Thank you so much. I want to call on Dr. Tuka Oyema. It was at the exam. Just wanted to let him make some comments what actually happened. Because he made some comments in the chat box. I just remember that it was at the exam. So Dr. Tuka, please.
Thank you very much. Good morning, everybody. Yeah, I remember in the exam, the rush, you were part of the presentation. And when I started initially answering the question, I was going on and about, can you hear me?
Yes, we can hear you.
Okay. I was going on and on about contrast, induced AKI, but I noticed they kept trying to, because I mentioned possibility of them, but kept trying to prompt me to put that forward, asking me questions leading to it. But I was not forthcoming until I came to the management when I now mentioned statins. I said, why am I using statins? And then I said, talked about the cholesterol levels and then dealing with the hyperdyslipidemia. And he asked me, am I still sticking with what I wanted to say? Was my main diagnosis. So it was obvious that it was not the conduct. And then looking at the fact that the patient had angiography, which, like I mentioned earlier here, the commonest trigger for most people that undergo angiography because of embolism in most patients, there has been some manipulation of the vessels, and then that can occur in angiography. Though most times it's with invasive coronary angiography than with CT angiography. But then there was angiography. What I'm not sure now is whether the exam specified the extent of the manipulation that happened. But from the body language of my examiners, and then by the time I was coming out, it was obvious and clear to me that this was cholesterol embolism. And even when I interacted with others that came out from the exam hall, it was the same thing all over. It was more of cholesterol embolism that caused the problem. The AKI had not the contrast-induced nephropathy like we would have thought immediately, and they're calling the question deliberately, knowing that it will throw you off towards contrast-induced nephropathy than the embolism if you've never heard about it. Thank you.
Yeah, thank you, sir, for the contribution. Okay, is there any other contribution, or we can just go to the chat box?
Yeah, so I just wanted to clarify that for the rash, you can have that in both acute tubular interstitial nephritis, the triad of fever, rash, eosinophilia, just like in patients with cholesterol emboli syndrome as well. So, and even some in CIN, that's a contrast in the you may also have rash because through delayed type hypersensitivity. So as I already said, the question was why says CT angiography. And my worry was the fact that they mentioned CT angiography. What they could have just said is PCI. Because the moment they say CT angiography, it means that it's probably just non-invasive CT angiography for this particular patient. I don't know what for, but you could have just mentioned PCI so that we know that there was catheterization because it was not clear. So all those things we can only assume that these are the possible causes and manage along that line. I that.
All right, thank you. Dr. Chibike said, will that blood pressure really favor hemodialysis? Patient will still benefit from
rashes that thought about that. More Lectularis livido kind of rash, and the contrast to I think was just the CT thing was just a gimmick to throw in a change in the question, and it did that in confusing me into thinking it's more of contrast.
Sorry, sir, please, can I say something, please, sir, if you don't mind? It's Dr. Nebo. Okay, sorry, he spoke about acute interstitial nephritis. You can't, acute interstitial nephritis can't be in this patient, considering the fact that there was most times it's as a result of drugs that causes acute interstitial nephritis or chronic interstitial nephritis. So I don't think it's something that you can mention in this scenario. That's number one. And number two, like the other doctor spoke, the rashes obviously indicates livido reticularis. If a patient, for you to do a PCI on a patient, you need some sort of angiography. I mean, you need to know where the obstruction is before the intervention. So that angiography is important in the first place. So I feel the patient already had a myocardial infarction, as in was like diagnostic. It wasn't a case of they were trying to see if the patient had MI or not. That way you can do the non-invasive whatever to make a diagnosis of MI. But it was stated that the patient already had a myocardial infarction and they now went ahead to do an angiography. Obviously it was I think it was like a form of intervention this time, because if you've made a diagnosis of MI, there's no point you doing a non-invasive angiograph. As in, I don't know if that makes any sense.
You can diagnose the MI on ECG with your troponins, so they can still. So you might have to have done the PCI because all those will be assumptions. Because likewise, we don't know the medications the patient was on, so we are only assuming. So I'm thinking that it's better to go all out, state the possible cause that could be in the patient. Then you can go instead of because they ask of a single.
Yes, that's understandable. But the thing now, that's understandable.
During the exam, I remember that the procedure was for treating the MI, not for the diagnosis alone. And the contrast was because contrast was used for the angiography. Because when we were doing angiography, you still inject a contrast into the patient to highlight the vessels. When your first analyze and show the vessels, then you now put in your stent and etc. And that's why the contrast came in. And the question in the exam, if I can remember correctly, was the procedure was more of a therapeutic, not just a diagnostic procedure. So there was some manipulation. It was more of angioplasty than angiography that the patient had from the exam. If my memory can allow me, it was more of treatment that they did for the patient. And 2 days after the treatment, when the patient was supposedly better, these symptoms now manifested. And mind you, I know in 2021, during the exams then, 2021, I can remember one of the sessions run by Professor Dan Bauchi, where they're handling MI. You come in and you don't mention angioplasty for the patient, you are wasting your time. He just laughs and says you kill the patient and you're out of the thing. So you can't have MI without thinking of angioplasty for the patient, not angiography. Graphy doesn't treat the patient, just you can use your AECG and make the diagnosis of MI. If you attend to the cath lab, you are planning to do angioplasty. I know that year, many people that we are, even those that attended and some of the chaperones, we even know that how Dambatu will laugh at you and say you've killed the patient once you did not mention angioplasty in your management for the patients that had MI. So in this case now, I think it would be safe to assume it was angioplasty because I think I recall it was more of treatment the patient had in that situation. And that would be more in line with some manipulation and that can give the embolization. Thank you.
Okay, sir. Then one more. Okay, sorry, ma'am. Sorry.
Okay, no, but you can round up after you. I will speak.
Okay, so sorry, I just wanted to answer the question. I mentioned it earlier about patients who can the BP favor hemodialysis. Like I said, the patient can do a slow, low efficiency dialysis or a continuous renal replacement therapy where you have the blood flow rate and what we call blood flow rate and dialysis flow rate reduced properly. So the tendency of those patients and the patients to be on the dialysis machine for a longer period of time. They can be there as long as 24 to 48 hours, but with a lower blood flow rate and dialysis flow rate. So that way they would not have the tendency of having hypotension. Thank you.
Thank you, ma. Thank you so much. I must appreciate the speaker. If Tito is so proud of his speakers, the nephrologists are picking up now. I wanted to come in. I was at this exam. I wanted to correct Dr. Prince. Please, in exam, look at your question and answer your question. Don't go to different places. Most time they want you to be specific because they ask a question. Which drug will you give? That's why you did not have answer to that question. Because you were thinking more in line of contrast images. Town, it's what I went to town, I'm just talking. So they recall, but once you come back, you think you can recall everything. So we usually advise once you go for exam, they give you a question, take a minute. Take a minute to understand the question. What do they want you to talk about? And be as specific as possible. But if you know you don't have an idea, like, oh, I'm not sure if this is this, if this is that, then hey, you can thank me. Please, let's mute our minds so that since we're recording, so that there won't be interactions and discussion. So, what everything said. So if they ask a question, please be specific as much as possible. Dr. Fatima, please mute the noise maker, please. Be as specific as possible. If you are not so comfortable, you are not so sure, that's when and only you want to gain as much. What advice to keep quiet? Never keep quiet in an exam. Talk and talk and talk. There will be something you will say that will make sense. So just keep talking. That is if you are not sure. But if you are sure, why will we be going to different places? There's no time. The exam is very short. There's no time. For example, my name is the time is over. There's no time. So be as specific as possible. Only go to become general if you are confused. So that you always advise, do not keep quiet. Do not keep quiet. Keep talking, keep talking, keep talking. So please, Dr. Prince, just to correct that idea that if you see a question like this in exam, go to town. No, there's nothing like going to town. Be as specific as possible. So I don't know if Chief Chitu just want to fine-tune most of the things that have been said. Chief Chitu, sir, Chief Remy goes.
Dr. Christopher, are you sure you want to bring me into this? Because I'm going to turn everybody's head upside down now.
Chief, no, this is all.
I should go ahead and turn everybody's head upside down.
No, it's a discussion.
Okay, everybody has been saying AKI, AKI, AKI. There is nothing here to indicate an AKI. They said the urea rose. We don't use urea to determine if a person is having AKI, do we? We use creatinine. All right, so I feel they threw all those things there to sway you off, to make everybody assume it is a contrast nephropathy. Okay, but it may most likely not be a contrast nephropathy. But I would like to swing towards more towards the cholesterol embolism. Okay, which could explain everything you found, but I wouldn't say AKI. All right, because indicators of AKI are clear. And of course, you need to have more than one UCR result to say that, yes, this is truly an AKI. But I like the discussion and how everybody looked at it. And yes, I support the diagnosis of a cholesterol embolism. Yes, contrast nephropathy will be one of the things that may come into the mix. Yes, they may have wanted to paint an AKI, and if that was their plan, then they didn't really paint it too well. It should have been clear. Okay. And then just to add to my nephrologist discussion earlier, other things you can do if a patient is hypotensive is to raise the amount of sodium in the patient in the dialysis, what we call sodium profiling. That too can also help with hypotension as well. Okay, so the person ends up getting more sodium from the dialysis, and then the blood pressure goes up. Kind of like giving your patient a dose of 0.9% saline while on dialysis, but you're not giving it. The dialysis is the one giving sodium to the person, so you can actually do that as well. But I like the discussion. It's well discussed, and well, I don't think I have much to add. So, Dr. Christopher, over to you again.
Thank you, sir. Thank you, sir. I must appreciate the two speakers. They did well, wonderful presentations, and I must appreciate the two speakers, gastroenterologist and the nephrologist, who was such a wonderful contribution from both specialties and other people. I don't know if I got to the news, but thank you for your contributions. It was quite interesting. You see, our teachers need to speak too much grammar today. Thank you, Dr. Chuka Yima, for coming to class and also contributing your bit. We appreciate your presence. Jennifer was in class earlier, but since she's gone, she come really early. Really must appreciate her. I know her schedule is quite tight. So, Dr. Jennifer, thank you in absentia. Thank you. Appreciate your presence. All the consultants in class, thank you, thank you, thank you. And I don't know, Dr. Fatima, then Dr. Chief to just round up the class and close. It's past 8.
I think you should just let Dr. Fatima round up. I'm about to start a lecture with my medical students. So
okay, sir. Fatima, please round up. Let's close the class. Seems she's off too. Please, everyone, thank you for coming to class. Teachers, our participants, thank you. Please have a wonderful day, everyone.